uh, 63 years old female presenting with a loss of consciousness for about 1 day duration or nearly decreased loss of consciousness. But her condition started 11 days ago with severe headache and vomiting. And she came with a decreased level of consciousness and somewhat drowsiness. And we have CT and MRV also. Starting by what, doctor?
دكتور هذا العرض سي تي، خلينا نبدا بالسي تي.
خلي الاكزيال اول شيء جازان، ليش خليت الساجيتال بالبدايه؟ شنو اللي شفته عقيل بالسي تي؟
هو فقط نيتف دكتوره كذا، مو تمام، ما عندكم كونترا.
نعم دكتور.
بس استاذ سي تي سكان اوف ذا برين نيتف showing area of hypodensity in the right temporal lobe.
نعم.
يعني looks like وكأنه brain edema. No obvious mass lesion, no obvious midline يعني shift of midline structure, or even no obvious pressure on the nearby on the nearby ventricle. لا اكو pressure, slight pressure on the nearby ventricles. وما شفت بي كالسيفيكيشن ولا شفت اكو اشوف اريا وكانه هايبر دنسيتيز بالسراوندينج صلصاي، ممكن تكون سب اركنويد هيموريج او انترا
هاي الاريا
بارنكايمال.
الهايبر، وهاي الاريا الهايبر دنس within the hypodens area. لا هاي نورمال برين.
احس وكانه هاي نورمال برين، يعني سراوندينج نورمال برين، ما حسيت وكانه ماس او
شلون
او
تتاكد انه نورمال برين هاي؟
يعني هو احنا المفروض ننطي كونتراست استاذ،
او ما عندك
نقيس
كونتر.
الدنسيتي، نقيس
نقيس
الدنسيتي.
الدنسيتي بالضبط، نقيس الدنسيتي نشوفها انه هل هي the same density of the brain or higher.
دكتوره كزان اذا ممكن هاي المنطقه اللي هايبر دنس نقيس الدنسيتي ونقارنها باي منطقه حتى اذا كونترالاترال او نير باي. المين 47.
صار بها partial volume يعني هي.
اي يعني شويه اصغر دكتوره وخليها بالميد لاين. اصغر بالعكس اصغر، وخليها بنص نص هي هاي الاريا اللي نريدها. تمام عاشت ايدك.
اوكي كمل عقيل.
استاذ انا ما شفت يعني انذر ماس، ما شفت اريا اوف كالسيفيكيشن.
نعم.
و
افتحي لنا الساجيتال كازان، هذا الساجيتال خلينا اياه. اكو بعد فد شيء اب نورمال اخر؟
حركي بي دكتوره ولا معلش.
هو بالاكزيال مبين، اكو
يعني
بالاكزيال.
هو حقيقه بالاكزيال، يعني انا شفت في شيء تريفيال هنا، هو واضح وكانه الاريا مال اتوقع هذا الانفيرير ساجيتال ساينس، مو تمام؟
نعم.
وكانه اوباسيفايد هايبر دنس.
الانفيريور لو ساجيتال هذا الستريت هذا.
هو المكان مال الستريت، تمام، ستريت ساينس
مم.
هايبر دنس، ويعني اكو كانه بفلو فويد.
نعم.
فهي اذا الدكتور عندها ام ار اي ممكن نتاكد به. تمام. هسه هذا يعني ام ار اي فور ذا سيم برين ام ار اي فور ذا سيم بيشنت. وهنا هاي الاريا اوف الستريت ساينس شوينج كانه اكو سيجنال فويد، او لو انتنس سيجنال. فممكن تمشي ويا انه هاي ساينس ثرومبوسيس ويا الاريا.
شنو البيس سيكونس اللي تشوف بيها
والله استاذ، هسه
نعم.
احنا يعني هسه احنا ممكن سوي، اتوقع اللي ممكن نشوف بها بتر.
نعم. تسوي بيتر.
اي،
لو الكونتراست انهانسد ايمج او بيتر
هي مو قالت
كونتراست.
ما ممكن كونتراست.
بالسي تي ما ممكن
اكو ام
كونتراست.
ار في اكو ام ار في
ها، منطي
لا
كونتراست بالام ار اي دكتوره.
هيمو سيكونس وام ار في. نعم.
تمام، اذا ممكن
اعطيته
تعرضين لي.
اعطيته كونتراست بالام ار اي كازان.
لا ماكو، بس ام ار في.
نعم. وين الام ار في كازان؟ هذا
دكتوره
الرو
اذا
داتا
ممكن.
مال الام ار اي.
اي، لان مو ام ار اي.
سوري دكتور، هاي توف فلايت.
تايم اوف فلايت.
تايم اوف فلايت.
دكتوره كزان، هسه خلني نجي واحده واحده. هو اول شيء اعرض لنا السيكونس مال البرين واحده واحده وخلينا نشوفهم. راوينا التي 2، راوينا الفلير، اذا ممكن يعني اوكي، بالطريق نجي على السيكونس مال الفي.
هذا الفلير.
هذا الفلير،
نعم.
تمام. أستاذ, again there is hyper signal intensity in
نعم.
the right temporoparietal lobe
نعم.
with the يعني no significant surrounding edema و no obvious midline shift. والventricles هنا شكلها مو compressed. ماكو عندي obvious
خلينا
mark.
التي 1 خلينا التي 1 من فضلك. هو هذا نفسه وين رحتي؟ هذا اللي كان بالبدايه. لا لا، هذا اللي جو الفلير، هذا التي 1 هذا. ايه خلي امشي. ايوه.
والاريا هاي هم هايبر سيجنال اون تي 1،
نعم.
يعني اكو اندرلاينج هيموراجيك كومبوننت. دكتور اذا ممكن الدوي والسوي نشوفهن، حتى اذا مثل سوينا سبلت للوقت اختصار اثنينهم سوا، خلينا نشوفهم.
تريد سبليتين دكتور لو بس هاي كافي.
تمام. هسه عاشت ايدك السوي شفناها. اذا ممكن هم تحطين لنا اي دي سي بس على مود نتاكد من عنده.
يا عقيل
يعني
هسه
هو
all in all شنو هي هاي الكيس؟
يعني هاي كتوتالي انه اكو عندي اوباسيفايد فين، يعني ما بيفلو شكله. فاذا تمشي الكيس ويا سيربرال فينوس اوكلوجن with the area of hemorrhagic infarction، يعني hemorrhagic
قصدك ثرومبوسيس.
thrombosis، اي cerebral venous thrombosis with the hemorrhagic infarction.
نعم نعم ماشي. نحتاج بعد في شيء هذا البيشنت عقيل برايك؟
والله استاذ يعني هو المفروض هي على نفس السيكونسات. احنا يعني ما شفنا مثل، هو عاده نريد نشوف الكوز مال الثرومبوسيس. احنا ما شفنا لا ماستويدايتس، ما شفنا يعني ساينوسايتس، ما شفنا فيتشرز مال برين انفكشن اللي هي ممكن تكون البريدisposing فاكتور. بقى ممكن يكون هو يعني اندرلاينج هيماتولوجيكال ديس اوردر. يعني هاي بعد كورك اب فurther للبيشنت، بس كايمجينج يعني اتوقع استاذ كافيه. ممكن كونتراست استاذ مثل ما تفضلت، يعني فورم فurther كونفورميشن بعد ممكن نحتاج، بس يعني كحاليا هو اتوقع كافيه البيكتشر.
شكرا عقيل. يلا
شكرا
جزاك
جزيلا.
الله. احكي لنا على الكيس وروح على التوك حتى نختصر الوقت.
ماشي دكتور إن شاء الله. دكتور أولا بالسي تي يعني thrombosis of the most of the venous sinuses seen, which is isodense filling defect within the region of the superior sagittal sinus and also stress sinus and part of the sigmoid sinus. And the temporal lobe, there is hyper dense area which is showing intraparenchymal hematoma within the right temporal lobe and surrounding by vasogenic edema and mild mass effect, minimal subarachnoid hemorrhage also seen within the temporal lobe sulci. And in the MRV, MRA and MRV showing thrombosis of the venous sinuses also, and right cerebral cortical white matter area of the restricted diffusion inconsistent with hemorrhage seen in the right temporal lobe, also foci of restricted diffusion seen and the left cerebral white matter and the susceptibility artifact signal in the right temporal lobe seen, which is consistent with the hemorrhage as well as venous infarction with partial subdural hemorrhage seen. نروح للتوك دكتور لو.
اي نعم روح يعني.
Assalamu alaikum. I would like to talk about cerebral venous sinus thrombosis, starting by normal venous anatomy. The cerebral veins drain the brain parenchyma, which are located in the subarachnoid space, piercing the meninges and drain further into draining further into the cranial venous sinuses. The cerebral veins lack muscular tissue and valves. The cerebral venous system can be divided into either superficial cortical cerebral vein or deep subendymal cerebral veins. Superficial venous system, which are including the cortical venous vascular territory and also superficial middle cerebral vein, which is called sylvian vein, this pink area, and superficial anastomotic vein of Trolan and inferior anastomotic vein of Labim. Deep venous system consists of lateral sinuses, sigmoid sinuses, stress sinus, and draining deep cerebral veins, which including subendymal and medullary veins. Subendymal veins, they receive medullary veins and aggregate to greater tributaries, mainly into the septal vein, thalamostrate veins, internal cerebral vein, basal vein of Rosenthal, and vein of Galen. This diagram showing the superficial, also a deep venous system, including supersagittal sinus, inferior sagittal sinus, and the vein of Trolan, which drain into the supersagittal sinus, and inferior sagittal sinus, which aggregate with the bilateral internal cerebral vein. Also, thalamostrate sinus, which drain to the internal cerebral vein, and aggregate into a vein of Galen and drain into the striate sinus. And on each side, there is a striate sinus, which drain in the vein of Labi and going to sigmoid sinus, then which are draining the bilateral cavernous sinus through the petrosal sinus to internal jugular vein. This red area, which is draining the cortical vein, are draining to the superior sagittal sinus, and the yellow area is sphenoparietal sinus, which are draining to the cavernous sinus bilaterally, and the green area, which are draining the vein of Labi, and internal cerebral vein, which are draining to the aggregating with the causing vein of Galen and draining to the striate sinus. Cerebral vein thrombosis are referred to the occlusion of the venous channels in the cranial cavity, including dural venous thrombosis, cortical vein thrombosis, and deep cerebral vein thrombosis. They often coexist, and the clinical presentation among them is very similar and non-specific. Diagnostic imaging features can be subtle, and any of the dural sinuses can be affected in isolation or combined continuous with another, like superior sagittal sinus thrombosis, trisinus thrombosis, transverse and sigmoid, including dural sinus occlusive disease and cavernous sinus thrombosis. Deep cerebral vein thrombosis is a subset of the cerebral venous thrombosis involving internal cerebral veins or paired paramedial veins, which course posteriorly along the roof of the third ventricle between the two leaves of the velum interpositum, and with different clinical presentation rely on which segment is involved. Deep cerebral vein thrombosis, which may result in thalamic infarction. Cerebral venous thrombosis account for less than 1% of ischemic stroke and typically affects young people. Risk factors including thrombophilia, antiphospholipid syndrome, pregnancy, puerperium, dehydration in children, and sometimes infection like otitis, sinusitis, meningitis, or trauma, head injury, jugular vein, or sinuses during neurosurgical procedure, or tumor with dural invasion. Clinical presentation ranging are variable from an asymptomatic to severe headache, which is the most presentation, about 90%, seizure, coma, and severe neurological deficit. CT is an enhanced CT is usually the first imaging investigation. It can be subtle finding relying on hyperdensity of the sinus being identified. Potential findings include direct signs, including cord clot sign, dense vein sign or sinus for the first week, 7 to 14 days, vasogenic edema secondary to venous hypertension, unilateral or bilateral cortical or peripheral venous hemorrhage, including Cashonec sign. This is the cord sign showing hyperdensity in the right transverse sinus. Dense vein sign, there is a potential pitfall in the interpreting the distal superior sagittal sinus as being hyperdense near the torcular hierophyllae. It is important to appreciate that normal blood within the dural sinus is usually of slightly increased density relative to the brain parenchyma, and that true hyperdensity is the key to recognizing the thrombosis. And the wall of at this location can be thick and measuring about 2 to 3 millimeters. And this is the dense vein sign and Cashonec sign, which is a small concave, just a cortical intracerebral hemorrhage. And there is a signs of contrast enhanced, including empty delta signs, which is specific to superior sagittal sinus thrombosis, gyral enhancement, or prominent intramedullary veins. This is an empty delta sign, which is specific of superior sagittal sinus thrombosis during contrast-enhanced CT. And deep cerebral vein thrombosis is area showing the right internal cerebral vein thrombosis. And another modality is CT venogram with contrast administration, especially with the CT venogram. A sinus filling defect is thought. Multiple non-reformative CT venography has been reported with a sensitivity about 95% for this diagnosis. In the blunt head trauma setting, there are findings that correlate with the increased risk of dural venous sinus thrombosis and thereby promote CT venogram confirmation. Like skull fracture that extend to the dural venous sinuses, skull-based fracture that involving the groove for the sigmoid sinus, and dural sinus hyperdensity and intrasinus gas. This image showing the sagittal sinus thrombosis during CT venogram. And there is another modality with CT perfusion, also not used routinely in the clinical practice. Whole brain CT perfusion may assist in establishing the diagnosis of CVT by detecting perfusion abnormalities that do not correspond with the arterial territories. And this area is showing perfusion or signal abnormality that is not corresponding to the arterial territory. And the MRI is able to both visualize the clot as well as the sequel. A conventional spin echo sequence may demonstrate an absence of normal flow void on the dural sinuses. The clot actually is isotense on T1 and hypointense on T2, mimicking flow void, with subacute clot becoming hyperintense on T1. All the findings listed in the CT section are also seen on MRI. The most sensitive conventional MRI sequence for detection of the clot is susceptibility sequence, such as SUI or gradient echo. Overall, the conventional MRI sequences combination are very sensitive but relatively nonspecific in the detection of dural venous sinus thrombosis. Contrast in 3D-T1 weighted gradient echo is the most sensitive and specific MRI sequence in the detection of deep vascular venous system thrombosis. MRV will demonstrate a lack of flow. As shown here, there is a flow void in this T2 weighted image, but in acute stage, and MRV showing absence of flow in the left transverse, also sigmoid and left partial internal jugular vein. Sigmoid sinus thrombosis, including dural sinus occlusive disease, is an infective form of dural sinus thrombosis, including thrombophlebitis, commonly seen in the setting of acute otomastoiditis. It typically presents with severe headache, high fever, 6 nerve palsy, and altered level of consciousness, which is shown in this area, with the presentation is somewhat differ from the others, showing the left sigmoid sinus thrombosis. And about the treatment, in 50% of cases, cerebral venous thrombosis progress to venous infarction. Unlike arterial infarct, venous infarction usually presents after some days. The mainstay of hyperacute treatment is heparin, even in the setting of hemorrhagic venous infarction. When the patient is stable, anticoagulation commences, including direct oral anticoagulant warfarin, generally at least 3 months, and interventional neuroradiologist or neurosurgeon can perform catheter-directed thrombolytic in the affected sinuses. In patients who are critically unwell with pending brain herniation, observational data suggests that improved outcomes in selected patients managed with decompressive craniectomy. Prognosis of the natural history of cerebral venous thrombosis is highly variable, with some patients having minimal or no symptoms and an eventual recovery above 65%, whereas others have a fulminant course culminating in extensive venous infarction and dependency or death up to 20%. Differential diagnosis, including arachnoid granulation, also known Pacinian granulation, are projection of the subarachnoid membrane villi into the dural sinuses that allow CSF to pass from the subarachnoid space to the venous system. usually characterized as well-defined focal filling defect within the dural venous sinuses, measuring about 2 to 9 mm in diameter. These are more common in the lateral aspects of the transverse sinuses and should follow CSF signal intensity on all MRI sequences, which is showing here following CSF signal intensity in T1 and T2 weighted images. And asymmetric anatomy, hypoplasia or atresia of the transverse sinuses. The right transverse sinus is larger than the left in most cases, in most patients. If the sinus is small or absent, then the ipsilateral sigmoid sinus and jugular fossa should also be small. This is another differential diagnosis, which is congenital or absence of the left transverse or sigmoid sinus, showing a hypoplastic transverse sinus. And thank you so much.